Now it's my great pleasure to introduce our next keynote speaker, Dr. Eric Kuhn. He's an esteemed associate professor in psychiatry and behavioral sciences here at Stanford University. He also serves as the co-director of the Stanford Mental Health Technology and Innovation Hub, where he's pioneering new approaches in digital mental health. He has a distinguished record of service with leadership roles in Stanford and the VA, behavioral telehealth and technology work group, and those activities have been recognized in numerous awards. He's a national leader in leveraging technology for mental health, and today he will share his insights on the future of digital innovation in the field. Join me in welcoming Dr. Eric Kuhn.
No, just Good morning, everybody. This is such an exciting event that I look forward to every year. And so it's really an honor, Leanne, for me to be standing up here today and to be included with such esteemed kind of co-presenters at this symposium. So I'm going to talk about digital therapeutics as a new class of therapeutics. And so I'll go through kind of what they are, and then I'll give you a case example of coming out of our center about PTSD coach. I'm going to try to navigate both my slides and these slides. So as I said, it represents a new class of treatments, and there's no real clear definition. There's no one definition of what digital therapeutics are at this point. We do have a broad definition from Nick Jacobson and Lisa Marsh from Duke, who recently published a great book about digital therapeutics for mental health and addiction. And so really, I think the gist of it is that it's software that's delivering the intervention, right? So whether it's prevention, treatment, or management of a disease, the software is doing it. And so you can see here with the Digital Therapeutics Alliance, which is a nonprofit trade organization. They also have a similar definition. The FDA doesn't have a definition of digital therapeutics. They have software as medical device. And so you can see there that it's intended for use in diagnosis or the cure, mitigation, treatment, or prevention of a disease. And so it really is about the software delivering the intervention. So why do we need another class of therapeutics, right? Well, I think as Leanne had mentioned, the statistics are stark, right? So half of the world's population will experience a mental health condition in their lifetime, so up to age 75. And the global prevalence of mental health illness is going up. This is largely driven by the fact that we're living longer, and so we're more likely to develop a condition. And then what's really super stark is that 70% of the individuals with mental health disorders receive absolutely no treatment. So it's a real kind of tough affair right now. Well, you know, we need to think about what's going out there in the world. So in the world, we just don't have enough mental health care providers, right? So we most likely never will, right? We just will never be able to train enough people and have enough people to meet this unmet need. So if we look at this is the psychiatrists per 100,000 people around the planet and in each of the countries. And you could see that huge swath of green and white where there's less than 5, some places 1 or less psychiatrists in a whole country, right? So how are we going to meet this need? So it's really not just a rest of the world problem. So even in the US, there's 160 million Americans who live in mental health professional shortage areas. So you can squint your eyes and you can see the gray, right? That's where everything's good. Everywhere else, all of that blue is where it's difficult to access care. In fact, less than half American adults with a mental health condition received any services in 2023. So, but mental health provider shortage is not the only part of the story. So even where treatment is readily available, like in VA, most individuals with a mental health condition will go untreated for reasons such as stigma, high cost of care, lack of insurance coverage, logistical barriers, so not being able to get to treatment, not being able to get time off from work or childcare, all of those things that could prevent them from going to treatment. And then what I like is this last one, which is that individuals have a desire to resolve symptoms on one's own. You might find me on the weekend, trying to change the wax ring on my toilet bowl, because something's leaking. I'm going to YouTube, I'm going to figure it out. And then before I know it, I break a pipe and I have a plumber at the house and I'm spending thousands of dollars. But we do try to resolve things on our own. And if we give folks the tools, maybe we can help them to do that. Therefore, I think alternative treatment options are needed that can overcome availability and other barriers to traditional care. So that's really where technology solutions can come in. So internet users, so this slide kind of represents right now, 2024, and the end of the decade, 2029. So it really, internet use is going to, and access to the internet is going to go from 5.35 billion users to 7.9 billion users. So 92% of the population at the end of this decade on the planet will have access to the internet. So we have a tremendous opportunity to reach people around the planet. And if you look at the other panel there, you can see that smartphone ownership, not going up as quickly, but it's going up by 30%. It's going to be up to 72% of the planet. People on the planet will have smartphones in their pockets and in their hands. So it's unprecedented reach to nearly everyone in the world that this technology will afford us. So we'll soon be able to reach all of these folks, but will we have interventions available for everybody on the planet? And here's some quick takeaways from what at this point is a pretty well-established literature of meta-analyses and meta-reviews, which are essentially meta-analyses of meta-analyses. So pretty well-developed literature. You could see that there's large treatment effects have been shown for digital therapeutics for anxiety disorders. And what might be surprising to everybody here is that these effects are similar to what we get when we do face-to-face treatment. So for anxiety disorders, medium effects for depression overall, and not different from face-to-face, especially when we include human support. So there might be some kind of hybrid blended models that'll be needed to get similar effects as face-to-face care. And then human-supported digital interventions, digital therapeutics, are more effective than standalone digital therapeutics. So that's probably no surprise to folks, right? So if we can get folks to engage more, there's supportive accountability, get them to do the things that the digital intervention is wanting them to do, they'll do better. And then CBT-based digital therapeutics are kind of the best, which is no surprise because they include information, education, and activities that folks can do to get better. And then there's medium to strong effects for depression and anxiety, respectively, in low and middle income countries. So really where that vast swath was when I showed you with psychiatrists in the availability on the planet. So that's really encouraging. So next, I'd like to share a bit about our PTSD Coach app as an example of, I would say, a somewhat reluctant digital therapeutic. We kind of came in before this whole idea was even, or this whole class of therapeutics was even defined. But from the very beginning, we considered the app to be a psychoeducation self-management tool for acute distress related to PTSD, which affects about 4% of the population on the planet. About 7% of, this is lifetime, about 7% of the US population will be affected by PTSD in their lifetime. So PTSD Coach is explicitly not intended to deliver or replace treatment, nor is it promoted as a treatment for PTSD. It's categorized in the App Store as a health and fitness app. So this is part of the kind of the issue right now with FDA and with other regulatory bodies about what would be what we would define as a digital therapeutic, because you can have essentially the exact same intervention and have it in the health and wellness, or it could be a digital therapeutic that you would need a prescription to use with your patients. So you can see a whole bunch of cool stuff about PTSD Coach when we launched it back in 2011. It got off with a really strong start. And it's free. You can get it in the App Store. You can get it in Google Play. Totally free to download and use. And we don't collect any personally identifiable information in the app. We get some business kind of analytics and those kind of things, but no personally identifying information. So over the years, we've gotten lots of great feedback from our users, and we've also done feasibility and acceptability studies. And so with all of the information that we're getting from clinicians and users and others who've reviewed PTSD Coach, we've continuously improved it. And so this is our current version, 3.1. There's been some updates, so there might be a 3.1, 3, 4, something like that after that. But you can see here that that it's got a good look and feel, and it's got good user ratings in the app stores. You can also see, if you look at the fourth panel there, you can see that it actually can be rendered in Spanish. So what's cool about that is that opens up 500 million people on the planet who speak Spanish to be able to use PTSD Coach. That's really kind of a cool thing about scalability, that by changing it to a different language, you can get that. I just have to have a huge shout out to our mobile apps program at the National Center for PTSD, especially Jason Owen and his team, who spearhead all of the updating and development. This is a huge task. And we also have, as should mention, we have about 16 other apps out there, including like Insomnia Coach and CBTI Coach, and lots of good apps that are available for free to the population. And collectively, they've had almost 7 million downloads at this point. So in terms of data on efficacy, we've conducted a number of RCTs on PTSD Coach, including our very first with the late great Bart Taylor, who was here at Stanford for a number of years, testing the feasibility, the acceptability, and the potential efficacy of PTSD Coach. So when we develop PTSD Coach, we're in the VA, we work with veterans, this is chronic PTSD. The idea was that we could give them something that they could use in the moment that might support some self-efficacy, some coping. They could feel a little bit more empowered, but we didn't expect it at all to improve PTSD symptoms. It wasn't designed like that. It had all of the PTSD type CBTI skills and progressive muscle relaxation, great psychoeducation, but we weren't expecting it to move the needle at all on PTSD. So to our surprise, what we found was, and we didn't know how long we should be putting an app out. This is before there were apps. This is 2011, 2012, when we were starting these studies. What we found was that we didn't see a condition by time interaction. It was over a 1-month period of using PTSD Coach. But we did see that the effect size for PTSD Coach relative to the effect size for the waitlist, it was significant. So kind of intriguing there. Maybe there's something happening. And then at 2 months, we saw a rather large effect size on PTSD symptoms. We didn't take the app away. And then when we crossed over the waitlist folks, we actually saw a similar magnitude effect size as the folks who had gotten PTSD Coach in the initial month. And so that was kind of intriguing. So this large symptom improvement, we also looked at clinically significant improvement. So a 10-point change on our gold standard kind of self-report measure of PTSD, which is the PCL. And you could see here that 40%, roughly 40% of the folks who got PTSD Coach for that first month had a significant improvement in their PTSD symptoms. And then we crossed over the waitlist folks, almost 50% also had a clinically significant improvement. So we were kind of floored by this. We were expecting no movement on PTSD. These are actually in a community sample, not with veterans. So based on these data, we designed a bigger study, a bigger trial, and we modified some of the design. So instead of only 1 month, we saw that big effect at 2 months. So we increased the intervention period out to 3 months, so more typical of what you would see with a psychotherapy study, 12 weeks. And then we also we had a higher criterion for how severe the PTSD symptoms would need to be. So this was more in line with subthreshold to full-blown PTSD. And so in this trial, what we saw was a significant interaction at 3 months. So the time by treatment interaction with the waitlist control, and that these symptoms, this symptom improvement was maintained out to 6 months. So I don't know, we were all surprised. In addition to these RCTs, we've published papers on data from hundreds of thousands of downloads of PTSD. And you can see here that in this study, we were seeing almost 50% of the folks who were making that clinically significant improvement on their PTSD symptoms. Pretty incredible. But we've also gotten all this other data from what we call in the wild, seeing if we're having a public health impact. So we are collecting some anonymous usage data out there for folks using the apps. And what we found is that there's a significant impact on the distress that they're having in the moment using a SUD scale. When they go into a tool and come out of using a tool, we get their change in SUDS. And so we're seeing that impact. And also we're seeing impact on their PTSD symptoms with the data that we collect. So I mentioned adding human support improves these outcomes for digital therapeutics. So we brought this into VA primary care with human support. So as folks are coming into our primary care setting, we have great interventions, brief interventions for anxiety and depression and drinking, but we don't have good interventions, brief interventions that can be deployed in the primary care settings. And what happens in VA is that folks who are identified who have PTSD are really reluctant to go to get mental health treatment. So can we maybe facilitate that for the folks who continue to have a need? So here you can see in this pilot, what we found was exactly what we thought we would find, that the self-managed PTSD coach, so just PTSD coach, here, go use it, versus the PTSD coach with clinician support, you can see that there's a big difference there between the two. And this was a very small trial with only 20 participants. You can see here for clinically significant clinical significance, we had 70% of the veterans were experiencing clinically significant improvement on the PCL, and that's relative to the self-managed group. And what's really cool is that we were actually able to, in these reluctant veterans, we were able to help facilitate them accepting and showing up to mental health treatment beyond primary care. So these are folks who were saying, we don't want that. And by the end of the treatment, they were saying, sure, I'll go and do that. So we conducted a larger randomized control trial with my colleague at the Center for Integrated Healthcare in Syracuse, VA, with 230 veterans in primary care. And what we found was that for the clinician administered PTSD scale, and this is relative to what they would get in primary care as is, the clinician rated PTSD symptom improvement was not different between the two. These lines are parallel essentially, so no interaction there. But where we did see some interesting effects was on patient reported outcomes with with a significant condition by time interaction at 8 weeks or at post-treatment. And then we continued to see that there was maintenance of symptom improvement out to 6 months. In terms of clinically significant improvement, we were seeing about 30%, 35% of the folks were showing clinically significant improvement, and that 41% of these veterans had a cut score that was below what would be probable PTSD based on the PCL. And that we were also seeing, although not significant, we did see that 50% more of those who needed mental health treatment, that is, they still met the clinical criteria on the PCL for PTSD, went off and engaged in care. And you can see that was not significant, and the study wasn't powered for that, but something suggestive there maybe. So fortunately, our veterans have access to world-class healthcare, all right, and PTSD treatment in particular. But what about underserved populations? So this is the North Carolina. This is my colleague, Sophia Smith at Duke, who probably within the first week that we launched PTSD Coach, she contacted me and she said, I work with cancer survivors. They have PTSD. this would be a great tool to have. There's a lot of folks in rural cancer survivors in rural North Carolina who have nothing. And so we were happy to share the code with her. And she developed Cancer Distress Coach, and we've tested it, and it has been showing promise. In fact, we have an RO1 that's getting close to being wrapped up. We have 500 participants with MSK, Memorial Sloan Kettering, and Duke Cancer Institute, where we're doing one of these SMART trials, so a sequential multiple assessment randomized trial, where what's happening is that we can kind of get a sense of how to use our treatments in a stepped care fashion to be most efficient. So this is a place where a digital therapeutic might come in and be helpful. So we're excited to kind of break the blind soon on this one and see how well PTSD Coach fared. We also brought PTSD coaching to federally qualified health centers. This is a collaboration with the University of Michigan, Rebecca Shrapata, who's doing a similar type study in these federally qualified healthcare centers. They're also known as community health centers. They provide primary care services to underserved populations in urban and rural communities, which are funded by the federal government, and they qualify for reimbursement by Medicare and Medicaid. So we're in year 3 of this study, another SMART trial, where we're seeing if we can deploy our scarce mental health resources in a way that we can figure out who might benefit from a low intensity treatment initially and then step them up, or who might benefit from low intensity treatment and not have to step them up. So I should just mention that in addition to these studies, we have several others that have or are or will be testing PTSD Coach with recently injured trauma survivors, patients in substance use care, and responders to the World Trade Center, which on September 11th, a few days ago, I was entering the IRB, and it struck me 6:30 in the morning today, September 11th, and I'm entering a study for World Trade Center survivors, responders, I should say. So it's really cool that, and these are folks in Florida who are mostly Hispanic, who were kind of in the cleanup crews, and the folks who are kind of working at the scene, who are kind of like the forgotten workforce. And so there's a professor at Florida International University who follows this panel, and we're going to be bringing clinician-supported PTSD Coach into that cohort. I should just share with you some of the global efforts. So what are we doing? From the very beginning, when we developed our mobile mental health program in VA, we were struck by Deborah Estrin and Ida Sims' Science article in 2010 with this idea of open M health. So this was the beginning, the iPhone hadn't been out that very long, but they really wanted to set this stage to kind of consider that we're not going to have a silo of this, a silo of these data, a silo of these, we should be open. And so we really adopted that ethos. In 2011 at ISTSS, or International Society for Traumatic Stress Studies, I organized folks and who were interested in the code, and we would share the code with them. So through GitHub, we essentially created a community of PTSD coach around the world. And so mostly not low and middle income countries at this point, but we have Australia, Canada, the Netherlands, Janine, we have in our group. And more recently, we have Ukraine. So with Code for Romania, an NGO, they've translated into Ukrainian. So we're super excited that folks are doing this. We would like to get more low and middle income countries. We've had countries like South Africa, China, and Tajikistan reach out, but they haven't created versions yet. We do have an Arabic version of PTSD Coach Online that's available. So very, very exciting. It's exciting really to see that these other countries are starting to test and publish on the efficacy, acceptability, feasibility of their versions, especially research coming out of Australia, Germany, Sweden, and the Netherlands. And our colleagues in Sweden actually just recently published the biggest trial of PTSD Coach for Sweden, where they showed a replication of our findings. So as a self-management tool, they found that post-traumatic, post-treatment, the standard mean difference was 0.45. And the waitlist controls, when you cross them over, you can see it's essentially the exact same as what I showed you with my work, our work at the National Center. let's see. I also want to draw your attention to this study, which was just recently published coming out of South Africa. What's interesting about this is that there's 1 to 2 psychiatrists per 100,000 people in South Africa. In this study, only 11% of the participants had English as a first language, and they used the US version of PTSD Coach with counselor support. And 65% of the participants in this study made less than $540 a year. So really an underserved, poor group of mostly women in South Africa who didn't speak English as a first language. And what we see here is at 3-month follow-up, 69% were below the clinical cutoff on the CAPS, on the clinician-administered PTSD scale, versus 27% of those in treatment as usual. But apps aren't the only cool thing smartphones can do. So there's much more that can be leveraged from these powerful devices, as we've seen in the previous presentations, right? So including data about frequency of calls, text, ambient sounds, light, Bluetooth connections, GPS, movement, et cetera, et cetera. And this is even, before we start connecting things to this device, this powerful computing device that's going to have lots of AI capabilities very, very soon with updates. So I think, capturing all of these data and other data can be potentially helpful in, as we've been hearing about, in predicting who might be at risk and helping to, in the moment, potentially help these folks. So I love this slide because what it demonstrates is how we take all of this sensor data. This is from David Moore. It's a slide that I probably have in every single talk. So how can we use these data streams to be leveraged for mental health treatment? So using smartphone data, so you can see the green down there at the bottom, we get that kind of the raw data coming off of the sensors. We can then into the yellow zone through analytics, we can develop some low-level features, and then higher level in the blue, behavioral markers, and then we can infer clinical states from that, and then we can potentially intervene on those. So lastly, I want to leave you off with where one of my early career awardees is going in this space, which is with just-in-time adaptive interventions. So really making these interventions more personalized, adaptive, and engaging. And so just-in-time interventions are interventions that adapt and provide support, for example, the type, timing, intensity, over time to an individual changing status and context. So in the moment of need, and knowing what the context and what's happening in that context at the moment and in the context that the person needs it most and most likely will be receptive. So this is really super exciting to me because knowing when somebody is in need and when they would be receptive to an intervention, because we all get dinged and beeped and we ignore it. Knowing when they're receptive is going to be important, but these just-in-time JEDI interventions are, I think, where we're going to be going, and using the analytics of precision medicine. So I'm hopeful that this will enable us to scale up precision digital therapeutics to have a tremendous public health impact to those with unmet mental health needs, not only here but around the world. So I'm going to stop there, and I thank you all.
So much for a very inspiring presentation. We have time for questions. A few questions, and then we'll deep dive in the panel session. I think there's one at the back, one over here.
Oh, great.
One at the microphone.
Oh, there's a microphone. So much.
Let's see.
Yes.
Why don't we take the one at the back?
Oh, is there a microphone there?
Who has the roving microphone?
Yeah, so
Okay.
Thank you so much for the talk. So your PTSD clinician supported data are so interesting, right? So, the digital therapeutics can increase impact so much, but when you have the clinician support, it's more effective. So, presumably non-specific social factors in clinical care, right? So, how do you think there's kind of a paradox, right? Like, how do you massively expand impact, take advantage of the digital therapeutic, but then also like not dilute the, the social
Yeah.
thing, like, so, I'm also working in this space, so it's something I think about a lot.
Yeah, cool. Definitely that is the tension, right? That you want to find the right amount for the person. How much do they need? Some people don't need a lot. Some people need a lot. And so I think there's, really cool work going on in task shifting. Like if it's the supportive accountability, it's not really about the intervention, it's program led. The digital therapeutic leads with support from maybe a paraprofessional, a peer or other, and really kind of figuring out how much that person would need of that support. And so, yeah, varying that support is going to be important because there's no value in if we're just bringing a digital therapeutic into psychotherapy and it's not going to, I mean, I should mention, we do have digital therapeutics that are intended to be used with psychotherapy to support homework and, assessment and monitoring. But yeah, that's really in terms of scalability. I don't think it's going to be self-managed or psychotherapy, but there's going to be a whole range in between that we're going to have to leverage other provider groups. Yeah, it'd be great to chat with you though about that. It's cool. I do not study that. We possibly could include that in future trials, but we have not done that yet.
Hi. I find it very interesting that you've got a smartphone digital therapeutic for PTSD, while in fact the smartphone is probably the cause of most of the major depression starting in 2007.
Mm-hmm.
So my question is, are those two things very different? That is PTSD very different from depression since they do overlap, number one. Number two, since those patients that are particularly smartphone depressed, primarily adolescents, is this an age-specific phenomenon? In other words, have you tested this in younger people? And number three, have you tried using PTSD Coach without the smartphone apps, for social media taken off, and does it make any difference?
Well, yeah, those are big questions. And I think we're still grappling with the impact of social media. And even coming in this morning, there was something on NPR about that. But we haven't looked at that. We haven't checked this in children yet. We haven't adapted the app. A researcher at Stanford, one of my colleagues, is interested in adapting these apps for children to see if they could be helpful. But I'm not aware of any kind of I don't know if that's the question, of intervention for potential social media type PTSD where we would use PTSD Coach. And then the other question was about the depression and PTSD overlap.
They're distinct entities,
Yes.
yet there's overlap. People have both.
Yeah.
And the question is it as effective in those patients, particularly when they're, being pelted with, social media memes and, directives that might be making things worse.
Yeah. And so we do have someone in our lab who is Dr. Haijing Hollenbeck is working on her areas on PTSD and depression in veterans and the impact on psychosocial functioning, and teasing all of that out using ecological momentary assessment data and passive sensing data, and then creating a just-in-time adaptive intervention based on skills like CBT skills that could be helpful in the moment. But what's driving what is the social media driving the depression are folks who are more depressed, spending more time on social media. Some folks, it's like television. Are you using television in a healthy way or an unhealthy way? Or it's like every technology.
Well, repeated measures analysis suggests that even happy people get unhappy when using social media.
I happen to like those funny videos of dogs and cats. So thank you.
You can have them.
Thanks.
Besides, they're eating the dogs and the cats.
Oh, yeah. You see, that's going to get me depressed and upset. So.
Hi, I was just curious, in the studies you mentioned, when you said treatment, what did that consist of? Like, was it use as needed or daily use for a certain amount of days, or like what was that?
So in the studies where it's self-managed, what we do is we just tell them to go use it however you'd like, just as if you had downloaded it from the App Store. In the clinician supported, we have a protocol. It's a 4-session, 8-week protocol, half-an-hour sessions where we check in with them every 2 weeks. And we prescribe certain activities, like like go in and do some psychoeducational kind of topics. What are you interested in? Let's write those down, and then work on some kind of a symptom over the next 2 weeks. Like if it's bothered by reminders of the trauma, or I can't sleep, and we would have them work on those, and then we would check in, see how they're doing. And those would be driven by the assessment in the app. So they do a PCL, and we could see what symptoms are the most hot, and the ones that, like through shared decision making, we would decide like, oh, this one seems like it would be a good idea. What do you think about that? Or which one do you want to work on? But with our trials where we just use it as self-management in our trials, we try to replicate what would happen if somebody went to the App Store and got it and they were just going to start using it, and
Did
we
you
don't
look at,
prescribe
like,
anything.
effectiveness by amount of usage?
So we are looking at that in these trials that we have. What we have now is research versions of the apps that are instrumented, that we can then get the data on the objective app use, and that we can then look to see. In these early trials, we didn't have that. In this latter trial that I showed you, we do have it, and Dr. Joe Vielgosh here in the audience is our data guru, and we are starting to look at that to see. And we've seen in other apps like our CBTI coach app, that use does seem to relate to the outcomes. So how much folks are using it is showing better outcomes. Oh.
Yeah, I'm curious if you experienced any regulatory issues getting products like PTSD Coach to patients, and specifically once you saw that treatment effect, did you have to get it classified as a software, as a medical advice with the FDA?
We have not pursued that. We believe it would fall under the discretion, enforcement discretion, because we are not marketing it as a digital therapeutic or as a software, as a medical device. We do, when we do IRBs, we have to click the box that this is software, but it's low risk. We haven't seen any issues, and we do collect data on whether or not folks are having untoward kind of experiences and outcomes based on using the app. So, but we haven't pursued that. There's no, it's a free app. It's available to anybody. We're not a company. We're the VA. We're the US government. So, and it seems to be doing some good. So, but it is something that we've thought about, like developing a digital therapeutic in earnest that would have like exposure-based elements in there, like real kind of evidence-based, trauma-focused kind of things. And that would probably then kick it up a notch, because there might be an added level of risk that folks would be signing up for if they were using the app.
Thank you.
Yep. Great.
We have one more quick question. We will make time for our next keynote, but do you want to take?
Oh yeah, sure. Go ahead.
Have you looked at digital technology for suicide prevention, particularly in the cancer patient survivors, where we're seeing a 10-fold increase in suicides versus the regular population?
Yeah, that's a great question. And, we have in VA, we have integrated care. So it's not just integrating mental health care into primary care, where we most think about it, but it's integrating into oncology as well. And so we've been talking with the directors at VA central office about bringing clinician-supported PTSD coach into those settings, because exactly that, we're having, especially with head and neck cancer patients.
Right, and in other high-risk groups, we're seeing it in gynecological cancers,
Yeah.
in cervical cancer patients.
Yeah, so we haven't gone there yet, but we do have a suicide prevention app that's available for free to the public that has a whole suicide prevention plan in there that VA uses, and it's an evidence-based plan. So,
And of course, in drug addiction patients,
yep,
the risk of suicide.
yep. Great, thank you.
Thank you so much, Dr. Kuhn.